Thank you very much, everyone. I'm really pleased that you asked me to kick off this your first AFNA webinar. And yes, I am working in China for sort of 3 months a year, not only in the Children's Hospital, which is 2,500 beds, which is the largest children's hospital in the world, but also in Shanghai at the Zhongshan Hospital of Fudan University, where I guided a PhD student. Title is COVID-19, the beginning and what we know now. So I'm going a bit further as China only. For this presentation, I have no conflict of interest, and I'll keep it short and sharp in time. Thank you very much. 4 issues in the next 15 minutes, 20 minutes. It's how did it all started off? COVID-19 in Shanghai, COVID-19 in Wuhan. Then the question to you all is, were we prepared, considering our work and our impact in our intensive care? And then I like to sort of start off with, or end off with, we need to reverse our clinical practice. And I've done some work with colleagues and friends in Spain. So this was the beginning. I just came back at home in the UK, in being a month in November in China, where the first noises came. Actually, there's something going on in Wuhan. And I asked actually one of my best friends, Professor Yusha Zhang in Shanghai, so what's happening? Well, she told me this: empty streets. There was an immediate response by the Chinese government to close down not only Wuhan, but quite some major cities. So this is the hospital I'm working in, Zhongshan Hospital of Fudan University in Shanghai. Their rapid response. And I was in nearly daily contact with my best friend, who is a nursing director of that hospital here, where I said, well, actually, this is going to be big. And I had this sort of vision that I thought, this is really going to be big. This is not something we get over it as SARS or something like that. I was really feared. My fear was we need to learn as soon as possible from you guys in China. So what I actually asked my friend is, Yusha, we need to write this up. I mean, you're doing so many things. You are frontline experience what's happening there. And we did. And we've been writing the story, how actually the hospital coped, what kind of guidelines they created, and how they actually experienced the whole situation in Shanghai. Because, yes, you can see Shanghai is a massive city, 27 million inhabitants. And on the 20th of January, the first COVID case was actually identified and diagnosed in Shanghai, which is a month later than Wuhan. But actually, you should remember that even Shanghai, early January, went into quite a lot of restrictions. So, because we had a big laugh actually at a certain point that my friend Yusha said, I now can drive 120 kilometers an hour on the highway in Shanghai. Well, I tell you, from my experience, you never ever can do that. So she had some quick runs, home runs, hospital home. Then on the 12th of March, they had 344 COVID patients. So we fairly quickly have been writing that up. The Journal of Advanced Nursing, the editor was really supportive, said, yeah, you can share this. So we had this quickly gone in, and it was accepted fairly quickly. And what actually we shared is this one. We like to share what actually most of the hospitals were doing. Because in China, the government actually said, we need to centralize the care. And we should have done it possibly in many countries here in Europe as well. China was really centralizing its patients into one hospital. So there was one hospital. If I would go back, there was one hospital, the Shanghai Public Health Medical Center was the hospital in Shanghai, 27 million people where all the diagnosed COVID patients would go into. And I think centralization here would save a lot of, time for the normal care. Because currently, obviously, we all know these days that we have a backlog of operations, we have a backlog of cancer treatments. Patients are waiting now. Where this system in Shanghai was actually quite good, where they were fully operational. However, as you can see on the left picture, temperatures were measured, and then everyone who comes into the hospital had to do a four-step procedure, including completing a survey, leaving behind your mobile number, your address, where you've been, with whom you've been, etc. So this is Shanghai. Now, time was running out actually in Wuhan. Was really, we all know that Wuhan went into a serious lockdown for quite some time. Now, what happened is the next thing then. I mean, here you are. One of our papers was a project. What happened actually is that Wuhan had obviously massive, this special hospital built, and how you man this? Where do you get all these nurses from? What actually happened is across the country in China, hospitals were deploying nurses to Wuhan. Now that was a massive undertaking, as well as the same happened at Zhongshan Hospital, where 107, well, actually 106 nurses and one doctor were deployed to Wuhan immediately in order to help them. And I'm still in daily contact with my friend Yu Zheng. I said, this must be a drama. This must create a lot of stress for them. And we need to measure this. This is going to be big. This is important. So we actually sort of quickly wrote a research protocol, got ethical approval. And the idea was actually to identify the stressors and burnout among nurses who were caring for frontline nurses for COVID-19 patients in Wuhan. Now, as you can see here, 107 nurses, actually 106 plus one doctor, were deployed. It was a fairly young group. 66% were less than 30 years of age, with a fairly limited of ICU experience, less than 8 years. Overall nursing experiences, even less in ICU only. They were caring for severe and critically ill COVID patients, and they were at least 1 month in the COVID units. So we came then in with an electronic supplement, a questionnaire, because obviously we use in Europe WhatsApp. In China, you have WeChat, which is a very nice system, maybe even more advanced as WhatsApp, where you can even do online surveys with. So we adapted a questionnaire that has been developed in Hong Kong during the SARS epidemic. And it has 3 subscales: stressors, coping strategies, and effective support. And then we use the Maslow burnout inventory. Most stressors, perceived stressors, were uncertainty how long current work status will last. Obviously, I mean, imagine this. You are deployed to another hospital, to another city. You don't want to be away that long. Now, worried about getting affected was 84% of these 107 who replied. And there was a lot of discomfort perceived by these nurses caused by the protective equipment. Now, when we looked at actually the other more analysis, that nurses in this study experienced considerable stress, and the most frequently reported stressors were related to family members. And if you look at the predictors for nurses with a younger age, less working experience, and longer working times in the COVID unit had higher burnout levels, particularly in the domain emotional exhaustion. So this was actually based, one of our first studies, I would guess, in the world when we were looking at what does it mean, stress. Now, obviously, I did yesterday a search about COVID-19 nurses and stress in PubMed. And then meanwhile, you've got one after the other study across the world publishing about the ICU nurses or critical care nurses or the emergency departments who are looking at the impact of COVID in our workforce. So this is one in the Netherlands, and there's another one in the Netherlands. So 2, one in the emergency, one in critical care. And actually both are saying the impact was quite severe, and it has its toll on our ED staff, or it has its toll on ICU staff. So keep that in mind. Now here comes a little bit the issue. To prepare or not to prepare, that's the question. Remember. Now imagine we are nearly more than 1.5 years on the go. Could we be prepared, or do we have to have all the new guidance and guidelines and protocols, for example, for family-centered care in the ICU? Do we have to identify and the wheel itself, or were we prepared? Now, here you are. Did somebody of you pick this up? 2 papers published in 2018. One is about the ethics of an outbreak, position statement part 1, all about therapies, treatments, limitations, duty to treat. There's another second paper, part 2, family-centered care. What do you do in the intensive care unit when you have a massive international public outbreak? It's all in there. Did somebody pick it up? I haven't heard it till a year later when we were on the go with COVID. So basically, if I would go and pick up part 2, they have 9 recommendations. And I tell you, if I show you these 9 recommendations, you all know. But you all invented yourself, possibly, in your own critical environment, yes or not. It's all about honestly disclose the unknown uncertainty to family members, because we don't know what's happening. And why are we excluding them coming into the ICU? Describe to patient family the decision processes. They are different during our COVID. They are. And that's what these guidelines already told us in 2018. Increase patient family communication. Find other ways. They already said that. They already described it in that paper. Anticipate the family self-protective behaviors, family coping. And it continues. Build a program of family-centered care to offer support. Yeah, because the whole family-centered care in the intensive care unit is changing throughout all units during the COVID. So it's a little bit, yeah, they already predicted this. And I really admire the authors of these statements. And obviously family-centered care. Judith Davison is the star in family-centered care, who published a lot of papers, but she has a lot of knowledge, and she had the idea to come up actually with these guidelines. So have a look, and I'm happy to share my PowerPoints later on the AFCNA website, where you can pick again to look at where the papers are, and I'm happy to send you the links of it, because I can't obviously not give you the full paper because you have to get it via your library. And it's really worthwhile looking at it. So my final message is actually, we need to reverse this. I mean, I think you would agree that it's time to reverse, possibly, because this whole, particularly if I link to the family-centered care, if I link it to our workforce, that it's still, people are tired. I see the news here in the UK, in the Netherlands, and in other countries that illness or sickness rates going up in the critical care workforce. I mean, it's terrible, and we need to get a hold of it. Now, I just want to share you one more piece of work I've done during this whole COVID, which was actually in Santiago de Compostela with Emilio Rodriguez Ruiz.